I'm Shane Gallagher. I'm a psychiatric NP at Bellevue Hospital, and I'm the practice facilitation lead and one of the co-Is on the study as well. Today, we're going to be talking about choosing, starting, and titrating medications for opioid use disorder. And so, just to review some ground rules, I see many of you have been doing so, but please type your name, facility, and role in the chat box. We'll be taking attendance to award CMEs. When possible, please turn on your video, mute your mic when not speaking. When you ask a question or make a comment, please just remind us your name, role, and facility. You can give case examples, but please try to minimize PHI and maintain patient confidentiality. We welcome all questions, and anyone who wants to share to try to help elucidate an example with the group, please do so. So topic overview, we'll be going over the 3 FDA-approved medications for MOUD, medication for opioid use disorder, also called MAT, medication-assisted treatment. So that's buprenorphine, methadone, naltrexone, and then we'll talk about a couple of special situations, including switching over from one medication to the other, and we'll talk about some considerations for special populations. This is just acknowledgements for folks who helped out with the content. So pharmacotherapy for opioid use disorder. As we've been mentioning, methadone, it's federally registered opioid treatment programs, also known as OTPs, or patients and folks often call them methadone clinics. So that is the only place where, on a maintenance basis, so outside of the hospital, that patients can be given methadone for opioid use disorder treatment maintenance. Buprenorphine, we'll talk a little bit more about the DATA Act, the Drug Abuse Treatment Act of 2000, also what established the X waiver. This particular piece of information is a little dated, the 8-hour training that recently has been waived for physicians. So it's actually more streamlined and easier for folks to get an X waiver. So if you're interested, please let us know. Any physician can provide office-based treatment. And then PO, naltrexone in PO or IM formulations. We'll be talking a bit about both opioid antagonist treatment. So brief history here. In 1914, the Harrison Act was a federal act that made it illegal for physicians to prescribe opiates for opioid use disorder. Then in 1937, methadone was first developed and approved in Germany. And then in 1971, this was the first establishment of a federal methadone clinic. So as what we refer to now as OTPs. 1984, naltrexone in PO, so by mouth form, was FDA approved for the treatment of opioid use disorder. And then in 2000, we had the Drug Addiction Treatment Act, the DATA Act. That expanded the prescribing privilege to increase the amount of patients that physicians could see. And it permitted physicians to approve or to prescribe buprenorphine outside of OTPs as the Schedule III medication. In 2010, IM naltrexone was FDA approved for the treatment of opioid use disorder. And then in 2016, the CARA Act, Comprehensive Addiction and Recovery Act, expanded the prescribing privilege to nurse practitioners and physician assistants and increased the physician-patient limit up to 275. Something to consider, even though over the past 2 decades, there's been a lot of federal bills that have passed to expand the access to opioid treatment. It's estimated that only about 20% of patients with opioid use disorder are receiving treatment. And among outpatient chemical dependency programs, only about 30% of them offer MAT. So there is a disconnect between getting connected to counseling and kind of day programs and actually accessing the life-saving medications. So just to refresh what type of settings patients can receive these medications in. So buprenorphine, it has to come from a DEA X waiver prescriber in an office-based setting in hospital. or it can be given in an opioid treatment program. If you feel like your patient is high risk and would benefit from a program that is daily, OTPs do also offer buprenorphine films. Methadone outside of the hospital can only be distributed in an OTP, so one of these opioid treatment programs. Naltrexone, sometimes offered in OTP, although usually is offered in an outpatient setting because any licensed prescriber can prescribe this medication. It's not a scheduled substance, so anyone with prescribing privileges can prescribe both the oral and intramuscular form of naltrexone. So methadone and buprenorphine are both used to treat acute opiate withdrawal symptoms. So last lecture, we talked about the cows and kind of how to determine when a person has acute withdrawal symptoms. It can also improve pain control in the setting of withdrawal and pain. Although just to recall from last time, there often will be some opioid hyperalgesia. So the patient may be somewhat more sensitive to some of the pain and will likely have an upregulated opioid receptor system, so often will need higher doses than, say, another postoperative patient would need for pain control. Also, over time, when it's up-titrated and given as maintenance, it reduces opioid cravings, allows patients to engage in medical care, can be started in hospital and continued after discharge. So this is why we're kind of aiming to improve HBOT, hospital-based opioid treatment, because often patients, whether or not they come in for symptoms of withdrawal or overdose, if they have a comorbid opioid use disorder and admitted for, say, an infection, it can be a moment that the patient is more motivated and may want to engage, or at least interact with a staff member regarding like harm reduction measures. So buprenorphine and methadone in emergency and acute settings. So contrary to popular belief, while a patient's admitted into an acute service, the prescriber does not have to be X-waivered. And we just have cited here Title 21 CFR, which essentially says that for 72 hours, while the patient is admitted, a non-X-waivered prescriber can give buprenorphine for acute opioid withdrawal. So on the bottom here, you can see emergency treatment may be carried out for not more than 3 days. So often there is a gap in care, say on the weekend, if there's not an X-waivered prescriber, or sometimes house staff are wary if they're able or legally allowed to prescribe buprenorphine. And the answer is yes, you can. While in the hospital, everyone is protected and eligible through the hospital DEA. So some more information regarding the structure of a methadone clinic or OTP. Methadone maintenance indicated for people over 18, currently meet DSM criteria for at least moderate opioid use disorder, have a history of at least 1 year of opiate addiction before admission, and then provide written and voluntary informed consent. Exceptions are women who are pregnant, former patients up to 2 years after discharge, or within 6 months of release from incarceration. And these are dispensed daily through federally licensed OTPs, and there's daily nursing assessments, and patients typically will meet with a counselor or therapist on a daily basis to kind of check in, discuss relapse triggers, and kind of establish the recovery goals for the patient. Hence, counseling is mandated. And also there is serial and sometimes random drug testing associated to see not only if the presence of other illicit substances are there, but also to see patient adherence with their medication. And so here there's a picture of one of the methadone dispensing machines in liquid form in the OTPs. And you can see here, there's just kind of a basic chart in the first quarter. So from admission and through the first 3 months, the patient will usually get 1 take home a week, which is usually on Sundays. And there's also the exception on federal holidays. but typically the patients will come in Monday through Saturday. So they're coming for their dose each day for the nursing assessment and check in with their counselor. Then the second quarter, assuming that there's regular adherence from 91 to 180 days, they can get two take home a week. Then at the 181 day mark, they can go up to 3 and then so forth. So you can see they can go up to 1 month of take homes once they hit the 2-year mark. And this is assuming they're not missing doses. There's no concern for diversion. There's serial urines negative for other opioids and so forth. So a bit about the pharmacokinetics or properties of methadone. It's a full mu opioid agonist. It also has some action at these monoamine sites, so an NMDA receptor. It has some reuptake inhibition for serotonin as well as norepinephrine. Typically absorbed within 30 minutes. It peaks 2 to 4 hours. Half-life at steady state is 23 to 47 hours, and it reaches steady state 5 to 10 days. And so this is some of the benefit when a patient is up titrated to a blocking dose, which is what they usually call the dose when patients don't report cravings anymore at about 80 milligrams. This is why we can do the daily dosing. We can take homes because it has a pretty long lasting effect, but it can make it tricky when we're looking to switch because the half-life terminal elimination is kind of variable in folks. So up to 72 hours, it can hang out in the body. So it can, if you're looking specifically to transition from methadone to buprenorphine, it's advisable to wait at least 24 hours. But if someone has decreased hepatic or renal clearance, you may even want to wait a couple days and counsel your patient on how to take other medications to help eliminate some of the symptoms. So you want a COWS of 8 to 12 there. Another thing to note is it is a CYP 450 mediated drug. So it will have some interactions at CYP 3A4 and also 2D6 1A2. Formulations, so we just saw that machine, that's the liquid concentrate. There's also a dissolvable powder. Dispersible tablets or tablets used outside of OTPs for pain management, so either in the oncology or pain management setting, and that would be dosed TID instead of daily. So this is what I was alluding to. There is a wide individual variability. You can see there the half-life may vary in individuals from 8 to 59 hours. The average half-life is 24 hours. I have seen a couple of patients who are what we would call ultra-rapid metabolizers. So they do start to feel some level of withdrawal. It's usually more in the subjective realm. They get profoundly anxious, restless, feel like their skin's crawling. You don't usually see as much of the objective COWS symptoms, but there is a blood test you actually can send out. Usually not done in hospitals, but it is a send out that you can see if a patient is an ultra rapid metabolizer, because sometimes in the hospital you could give them BID dosing, but unfortunately, if they're in a program, they're daily dose. So it would be a matter of finding other kind of strategies to help them manage some of that mild breakthrough withdrawal at night. Methadone is approximately 70–80% bioavailable, but again, quite variability ranging from 36 to 100%. And again, the hepatic metabolism. So you may want to just do your drug interaction check with some common antibiotics, antidepressants, and antiretrovirals. So inducing somebody on methadone, the goal is to increase the dose gradually and safely. You're stabilizing the patient, reducing opioid use while recognizing the risk of dropout or overdose from most use may increase if induction is too slow. Should also treat acute opiate withdrawal symptoms. You may have seen these opioid conversion tables that help you convert morphine to oxycodone to hydromorphone and so forth. Methadone is tricky and doesn't neatly translate to these. So if you have a patient who's on opioids for acute pain management, it may be worth a consult, either with a pain or palliative physician, just to kind of check in. But often you're just going to titrate to comfort, kind of withdrawal symptom control, because there is no kind of gold standard conversion factor there. And opioid withdrawal is not required for treatment. So this is the case often in emergency settings. If a patient has very frank objective signs on a COWS, a lot of providers will treat clinically. And so this is saying, though, you don't necessarily need opioid withdrawal. If the patient has a positive UTOX and is using opioids, they can also receive doses of methadone. You may want to start a bit slower, just to kind of see a dose of 10 to 20 tablets come as low as 5. So you can start low, go slow there. Generally in the acute setting, if you do have withdrawal, you start somewhere between 20 to 30 milligrams with a maximum first daily dose of 40 milligrams for those with physical dependence. You want to observe for sedation after each dose about 2 to 4 hours. If there's no sedation but continued withdrawal, you can give 5 milligram as needed PRN doses, reassessing every couple hours. And then if they're sedated 4 hours after the last dose, you can decrease the next day total dose. Still, you can titrate up, but you may just want to kind of take your time a little more. The sedative effects can kind of stack. General rule of thumb in OTPs for reference is usually the doses will be increased every 4th day in the outpatient setting. Sometimes in the hospital, it may permit a quicker dose because you have more, you have closer monitoring, more access to serial EKGs and so forth. Okay, so we've induced the patient on methadone on the first day. The goal is to extend time without opioid withdrawal and then slowly titrate to address cravings without development of sedation. So we want our patients to be maximally functional, but also eliminating the cravings to use opioids. So dose adjustments are individualized, again, about 5 to 10 milligrams every 3 to 4 days in OTP settings. Hospitalized patients with physical dependence may tolerate a faster titration. So you can go up 5 to 10 every 1 to 3 days. On day 2, it's usually advisable to max out at 50, just because of the variable half-life elimination there. Then on day 3, you can give 50 to 60, so a 60 ceiling there. And then every 2 to 5 days, increase 5 to 10 milligrams. And so then effective outpatient doses, this is the blocking dose. They are usually somewhere in the 60 to 100 PO mark. The magic number I've usually seen is about 80. And then this helps the patient to manage cravings, keeping in mind highly variable due to the bioavailability and half-life. And doses may be needed that are much higher. There are folks who go up to upwards of 200 milligrams a day, but that would be over quite a long time, over months. And so dose considerations, considering lower doses is especially prudent in geriatric patients. So in inpatient settings, you can even dose starting at 5 milligrams just to see. If they're on other medications that are on the Beers list, you do want to kind of just watch out for the cumulative sedation there. Low estimated opioid tolerance based on history. So if you have a patient who is telling you that they're using 1 or 2 bags of heroin a day, you may want to just start them at 10, kind of see how they do, can go up to 20, but going much over that, the patient may feel sedated. Again, concomitant use of any other sedating medication. So especially if they're using benzodiazepines concomitantly or prescribe them, You do want to just watch out since both have carry a risk of respiratory depression. Same goes for alcohol. Other medications in the CYP pathway that may increase serum methadone levels and have medical problems that cause hypoxia, hypercapnia, arrhythmias, and so forth, such as COPD, sleep apnea, and so forth. So if you're inducing those without physical dependence, meaning they're not having signs of active withdrawal, you can discuss alternative treatment options, including naltrexone or buprenorphine. You want informed consent regarding physical dependence if they're going to go on to methadone. If patient prefers methadone, you consider starting 5 milligrams daily, titrating more slowly with dose increases every week with close monitoring for patient response to toxicity. And again, you individualize the dosing based on response there. This is what I had alluded to before. So serum methadone levels and the consideration of split dosing. So some patients, when on a stable methadone dose, they report feeling drowsy 2 to 4 hours after their dose, and then can have this rapid metabolism, developing cravings and even withdrawal symptoms before their next dose. This may occur in pregnancy if they're on medications that are inducing the metabolism, or if they just have this genetically rapid metabolization phenomenon. In the hospital or patients with pain, you may consider split dosing in addition to comprehensive analgesic and pain management plan. So especially, so say for argument's sake, in this case, the patient is saying they feel drowsy. If they're on 50 milligrams of methadone, you could even split it so that you give 20 in the morning and then 30 at night. You kind of optimize the sedative properties. You may need to, you may then spare using other sedating medications while in the hospital, and you can use methadone for to kind of exploit its sedating properties. Some precautions. So as we've been talking about the respiratory depression, this is particularly poignant during induction. And extra caution in those with any type of obstructive lung disease, sleep apnea, retaining carbon dioxide, or central apnea syndromes, including Pickwickian syndrome. Next, we'll go to buprenorphine. Quite a few different formulations. The one that folks are probably most familiar with are the sublingual tablet or film. Those are branded under Subutex or Suboxone. There's also a buccal film and a subcutaneous extended release form called Sublocade. So there's a picture there of the sub-Q injection there, as well as an implant. And these are other formulations that are FDA approved for pain and not OUD. The transdermal patch, the buccal film, and an IV formulation. So to remind us about the pharmacokinetic properties, unlike methadone, which is a full mu opioid agonist, this is a opioid partial agonist. So you can kind of see the difference here. Methadone and our other opiate agonists giving full effect here, whereas buprenorphine is a partial agonist, meaning it occupies the receptor, giving a partial effect of opioids, but they're not going to get the same impact. You see here, as opioid saturation goes up, this kind of euphoric effect folks don't typically get on buprenorphine, but therefore gives them less of the risks for respiratory depression and death. So the one thing particularly about buprenorphine is its high affinity. So it competitively binds to opioid receptors over other opioids, which is part of the protection that it provides from overdose with continued use. We've alluded to this before. Something that's key is there must be at least mild to moderate opiate withdrawal for induction. This would preclude folks who are coming from abstinence So if a patient had an inpatient detox or rehab with a period of full abstinence, you could induce, then they're not going to necessarily have withdrawal because they've been off opioids for quite some time. Also, a prolonged incarceration, assuming the patient's not doesn't have any access to MAT while incarcerated.
Shane, just to jump in, there's a recommendation in the chat that from Adam Zavadnik for those wanting to get Sublocade as outpatient and patient has Medicaid, they highly recommend using a ChemRx pharmacy. Oh,
yes, thank you. Yeah, I know. I think it was actually as of this year, or maybe last year, mixing up the years, they did add a injectable sub-Q buprenorphine to the Medicaid formulary. So yes, thank you for that info, Adam.
Yeah, I found that I have no stock in that pharmacy or anything like that. I just found that when we were starting Sublocade, we were sometimes making calls to Accredo every day, and it was just very confusing. And obviously, it doesn't go straight to the patient; it comes to the clinic, and it was an incredible amount of time. And then ChemRx will send it the next day.
That's good to know. Yeah, no, I have an outpatient practice where I prescribe buprenorphine, and it can be really tricky with different insurances covering specific formulations. So, and a lot of prior auths. So it is something to consider if you're an outpatient prescriber. You definitely want to make relationships with pharmacies, that kind of carry this on a regular basis and can streamline the process for your patients. So some definitions just to review pharmacology wise. So affinity is how tightly a drug binds to a receptor. And so in this example, buprenorphine has exceptionally high affinity at mu receptor, so much that it displaces and blocks a lot of your common opioids, morphine, methadone, oxycodone, and so forth. And it also will displace them. So this is why it's important for the patient to be in objective withdrawal, because they'll create that gap in that graph we saw. It's going to push them down to a much lower level of full agonist saturation, and therefore can cause profound and acute withdrawal symptoms. Activity is how much effect the drug causes at the receptor. So that's the principle of a full versus a partial agonist. So how we saw as that increases, that's when euphoria, respiratory depression start coming into the picture. And therefore, there will also be less analgesic or pain relief effects and sedation in comparison to full agonists. So that is something some patients will really like, especially if they're working or have family obligations and were sedated on methadone. Buprenorphine is as effective at treating cravings without that kind of sedation side effect. The rate of dissociation is how the drug disengages from the receptor. And so bup has a high affinity, but a low dissociation. So it's hard to knock off the receptor and dissociate slowly. So therefore is what's kind of helping us with protection, risk of overdose with other opioids. So like we're saying, buprenorphine, high affinity. You can see on an empty receptor there's a mu agonist. So it's saying perfect fit, kind of this is the full agonist giving you the more robust pain analgesic effect, as well as possible sedating, euphoria. There's going to be no withdrawal pain, but we're going to have some of the euphoria. In comparison, buprenorphine, imperfect fit, so to speak, the partial agonist there. It's going to limit the euphoric opioid effect, which you can see because of the high affinity, low dissociation. These other opioid molecules here are going to kind of bounce off the receptor and not be able to bind there. So to recap with partial agonists, lower abuse potential, lower level of physical dependence, ceiling effect at higher doses, and greater safety for the overdose. So the buprenorphine undergoes extensive hepatic metabolism. Average time to peak is 40 minutes to 3.5 hours. This is something to consider when you're inducing and you're concerned about precipitated withdrawal. It can take up to, say, like 30 minutes for the patient to experience those symptoms. Variable elimination, half-life 24 to 69 hours with a mean half-life of 24 to 42. That's why the current tips, SAMHSA tips, or FDA approval, you can dose once daily. Some patients like to take it 2 or 3 times a day because it mimics their patterns of use, giving them kind of some feeling of regularity using it throughout the day. But you can actually counsel them that it can be effective pharmacologically with once-a-day dosing. So they can take it once a day in the morning. It should cover them from there. So for opioid addiction treatment, it's sublingual. So the film, they hold it under their tongue. They don't talk. They don't have to swallow. And it goes through the mucosa and the tongue. So there's poor GI availability, which is why in the buprenorphine naloxone formulation, there's no GI absorption of the naloxone there. Typical dose ranging starting is 8 to 16 milligrams daily. Maximum is 32. Some patients need more than 24 milligrams is usually the dose that insurance will cover. So you likely will have to submit prior auth to get 32, but some patients still do have cravings at 24. So you can go up to 32 a day. Since it's slow dissociation, some take it every other day, or you can split the dose. But typically, I see most folks take it every day, unless they're trying to taper off. It's usually an everyday medication. And so some drug interactions, the hepatic metabolism. So CYP3A4 inhibitors, just want to keep an eye out for azole antifungals, some antidepressants, antiretrovirals, and then also keep in mind some common 3A4 substrates that folks may be on. So muscle relaxers, benzos, anticoagulants. And then as well, carbamazepine in particular, both a substrate and an inducer. So it'll decrease the blood level of buprenorphine. Folks may start feeling a bit uneasy, having some breakthrough withdrawal symptoms or cravings. So just may need to titrate the dose if they're on those medications as well. So prior to starting buprenorphine, you're going to diagnose opioid use disorder or acute opiate withdrawal in the patient. Counsel the patient on benefits of the medication and some alternatives, what the timing of induction will look like. Definitely want to educate them thoroughly on the risk of precipitated withdrawal. Sometimes if patients meet with you and then come into the office again, I found this, that when you remind them of precipitated withdrawal, they may be a little bit more honest with you that they did use some earlier in the day or the night before. So that's just something to counsel them on, that you really want them to wait to avoid this discomfort, that it's not a punitive thing. It's more of a clinical question the last time that they used, especially if they're coming off of methadone. So if they've used methadone in the past couple of days, it's something to consider that they might have some precipitated withdrawal. And then just counsel them on how to properly take the sublingual form. Patients at childbearing age, you want to do a urine HCG, and then you do a urine drug screening to establish a baseline of what is in their UTAPs. So opiate withdrawal timeline, they should be at least in mild to moderate opiate withdrawal in order to begin induction. So this is a COWS of 8 to 12. And so you want to focus on the objective symptoms more than the subjective. So seeing some diaphoresis, some piloerections, sweating, yawning, dilation of the pupils, measured heart rate, so tachycardia, these are all going to show you the presence of those, the handful of those, will give you a COWS of 8 to 12 if they have a couple of those, especially once they get to piloerection or goose flesh, they usually have quite a bit of other symptoms, especially if they're reporting, muscle aches and GI disturbance as well. That's a good time that they're probably insufficient withdrawal to induce. The start timeline, just a note there, you can see 5 to 12 hours is kind of a good window for shorter acting opiates. So if they're on oxycodone, but you may want to wait 32, even up to, sometimes I'd wait 2 to 3 days. If it's an older patient, decreased hepatic clearance, because if they're on methadone, it can kind of linger, give you some precipitated withdrawal symptoms there.
Shane, there's a question about whether pregnancy is a contraindication.
For which medication?
Maybe
Probably, I think it
both.
came up with Suboxone.
Oh, is it a contraindication for Suboxone?
That's the question.
Okay, so previously, I think it still is the guidance. It's not, that's the answer, it's not contraindicated. But for pregnant patients, I think the ACOG recommendations are to give them the mono product, so buprenorphine without naloxone. Although I saw something recently, I think there's studies that have shown there's not an increased risk in giving patients who are pregnant a combo product, but I don't know if the guidelines have been updated. So as of now, folks still typically give Subutex or buprenorphine mono product to patients who are pregnant. With that being said, this slide is focusing on specifically the combo products, so buprenorphine, naloxone. The idea of it was to deter intravenous use of buprenorphine. So if the film or tabs of buprenorphine are crushed, it activates the naloxone and deactivates the effects of buprenorphine. Pharmacologically, as we were saying before, the naloxone has poor GI availability. So since it's absorbed sublingually. And then bupen and naloxone have similar affinity for opioid receptors. Okay. All right, so here's a checklist for when you're thinking about inducing buprenorphine. One of the keys is you're gonna make sure you're making a diagnosis of opioid dependence or opioid use disorder. And then you're going to kind of go from there, seeing are there current signs of withdrawal, then you would treat with COWS at least 8 to 12. Or if we talked about if the patients had a window of significant abstinence, you don't have to wait for withdrawal. I'll let you look at those. Those are just kind of some of the other ones we've talked about. The interest, considerations for pregnancy, we just talked about. And then also you want to consider concomitant drug abuse. So if they have a co-occurring alcohol use disorder, wouldn't be contraindicated, but you would want to kind of counsel them on the risks of using both and the risks of other benzos, barbiturates, or sedatives. And so this is review. So there are clear signs of opiate withdrawal, a COWS greater than 8. Again, we're focusing in on more objective symptoms. So if the patient is just reporting anxiety, restlessness, mild GI, you might want to wait a bit. So the induction dose, depending on what's available to you, you can start as low as 2 milligrams or a 4 milligram sublingual strip. And then after 2 hours, you want to give an additional 2 to 4 if there's continued withdrawal, as long as there's absence of sedation. You individualize the dose, again, based on how much opioids they're currently using and the level of physical dependence, as well as the severity of withdrawal. The suggested dose for the first day is up to 12 and then up to 16 on the second day. So we're checking cows when patients awake, endorsing withdrawal symptoms. If the cows is less than 8, you want to repeat it every 1 or 2 hours using adjunctive meds to address any present withdrawal symptoms. And then once your cows has reached at least 8, you want to provide the initial dose of 2 or 4 milligrams. So then from there, say you're treating them in an acute setting. If they don't want maintenance, you would taper off by 2 milligrams a day prior to discharge. If they do want maintenance, you would increase by 4 to 8 milligrams daily with as needed for withdrawal, and hopefully getting up to a max before discharge of 24. And then at discharge, you want to prescribe a bridge prescription depending on when their appointment is. If they're able to get one within a week, you can give them a week's supply. If there's more of a wait at the particular referral provider or clinic, you can give up to 2 weeks. And then you would schedule follow-up, ensuring that there's a provider who's X-waivered at the site. I think we've gone over these before, but just a quick review. These are adjunctive medications. They're great in the inpatient setting. I personally have a lot of luck with clonidine. You do have to kind of sell it that it's going to address their kind of like classic withdrawal or dopesick symptoms. So a lot of the sweating, since it's an alpha 2 antagonist, tell them that it will help with some of that heart pounding, anxiety. And I often like to optimize it with hydroxyzine or Atarac. Good anxiolytic, helps with some of the restless feelings. If they are having really bad kind of muscle aches, NSAIDs and Tylenol, also muscle relaxers, baclofen is often used in opiate withdrawal setting. Ondansetron and loperamide for nausea, vomiting. If the patient is having kind of severe anxiety, very restless, it's reasonable to use low dose of benzodiazepines as well, to kind of wait until they can get into withdrawal there. So if we're looking to switch from methadone to buprenorphine, a dose of 20 to 30 milligrams a day for 1 to 2 weeks is optimal. Starting bupe, as we said, no sooner than 24. I'd say it's usually advisable to go a little longer if the patient can tolerate it. There is also a kind of cross taper where you taper to the point of objective withdrawal and then give microdoses of buprenorphine. Advise them, if they can, to take some time off work during the transition, and if they have family support to help with children, other responsibilities, as the discomfort can last for 1 to 2 weeks. The priority here is to reduce the risk of precipitated withdrawal, and there's high risk of relapse here. And transferring from higher doses, this should be undertaken after consulting with usually the person at their OTP. So if they're at, say, 80 milligrams, one of the blocking doses, it's going to take quite some time for the patient to taper off methadone in the span of typically months at that point. For patients at high risk for returning to opioids after a period of abstinence, doses should begin at a lower dose. So you can even give half a tab, so 1 and 0.25 of the buprenorphine naloxone, or 2.5 daily. And these dose adjustments should occur slowly. For the patient who's opiate naive, they've either completed detox or been incarcerated without access to MAT. And consider an induction either in office or a supervised induction if they're inpatient. And then this is a suggested induction and stabilization dosing schedule for buprenorphine. So this is just a review again of the sublingual formulation. So sometimes if they're not taking the medication correctly, they may not be getting the full effect. So you want to make sure they're placing it under their tongue They don't need to be swallowing saliva, keeping it there for 10 minutes. I usually tell them not to talk, don't eat, don't talk during these 10 minutes, and then make sure that the tablet's fully dissolved. So just kind of education to provide to patients who are starting out. Recognizing precipitated withdrawal. So this usually occurs within 30 minutes after the first buprenorphine dose. And it essentially is going to look like worsening opiate withdrawal. And at this point here, it's not subtle. It usually, when I've seen it, the patient is very nauseous and usually feels like a very sudden urge to throw up. So if you get this kind of quick onset nausea with a lot of anxiety, sweating, it's likely precipitated withdrawal if they've just gotten their first dose of buprenorphine. Paradoxically, and this is kind of a counseling point to discuss with the patient before and during, you generally push forward with the induction. And this is counterintuitive. A lot of times, if a patient took a medication that just made them feel really crappy, they're not excited about going into it more. But this is where good education kind of counseling with them. If they take a couple more doses, so you can start with 2 milligrams every hour, or sometimes giving an 8 milligram. If it's really severe, just giving them an 8 milligram will usually resolve the precipitated withdrawal symptoms. If you find that they're still having kind of a lot of anxiety, palpitations, you can give some of those non-opioid adjuncts that we discussed before. Again, if severe, low-dose benzodiazepines can be helpful to manage some of the anxiety and fear of going into withdrawal. And so this is an example, microinduction, so taking withdrawal out of the equation. This, I would say, in your hospital, if it's not standard practice, consult with someone who's done it before, because it is kind of more of a pro tip and a little tricky to successfully do. But it is possible that you can introduce buprenorphine gradually without fully stopping the patient's medication. And it's usually with short-acting full agonists. I haven't seen it done as much with methadone, although possible if you get them to a very low dose and the patient really can't experience or tolerate withdrawal. Special populations. So there's a question before regarding pregnancy. So methadone was previously the standard of care. Now we try to have folks on buprenorphine if we can, and not stop it during the peripartum phase. Definitely like to continue it if possible. This point here is about specifically with the combo product. There is potential withdrawal, so neonatal abstinence syndrome is a consideration. So the dose could be lowered at that point. And then, so there are some case reports for its category C. Although pregnancies generally progress normally, there are few reports of prematurity or other complications, but generally safe during pregnancy. Neonatal abstinence syndrome. So buprenorphine, again, since it's a partial agonist, it's going to be less intense than with methadone. Appears first 2 days of life, peaks within 3 to 4 days, and usually resolves within 7 days. Treatment is opiate tincture, and there's poor bioavailability of buprenorphine during breastfeeding. But this is something to discuss, with an OB team and an expecting mom about possibly needing more intensive care when the baby's born for NAS. Considerations while patients on co-occurring pain management. So with methadone, you continue the daily dose. There's in this point, considering splitting dose into BID or TID, that would be if the patient has a prescriber in an oncology or pain management setting. And then you want to titrate short-acting analgesics, keeping in mind that they may need 1 to 2 times the normal dose, because The methadone is keeping them out of withdrawal, not giving them any pain relief. And with buprenorphine, there's two options. One, you can titrate the short-acting analgesics using high potency. Because remember, with the high affinity low dissociation, oxycodone, morphine aren't going to work. So you would have to use hydromorphone or fentanyl, ideally in an observed acute setting. 1 to 2 days after last bup dose, other opioids will start to have more effect. The other is to titrate buprenorphine. Although if you're seeing an inpatient who has severe pain, you're not likely going to fully resolve kind of their pain with even titrated up to 32 milligrams a day. So you likely will have to add other opioid analgesics or consider some other adjuncts, ketamine, local regional anesthetics, or gabapentinoids. Adolescents, it's FDA approved for age 16 and up, can be used in the detox setting. Consider naltrexone as a post-therapy adjunct. Laws vary by state regarding parental consent. Again, this is what we've been talking about, just start low, go slow with geriatric populations, since there's different metabolism, risk for polypharmacy with other medications on Beer's list. Let's see, oh, we're almost at 10. So you can see there's about 1,200 OTPs in the country, about 36,000 waivered physicians in the country. So this is OBOT, office-based availability. OTPs, as we talked about, can dispense methadone, bup, or both. Often don't have integrated medical services, some do. This is just a review. We talked about these, some of the federal regulations. When referring a patient to OTP versus office-based opiate treatment, so one is geographic location. Do they have access? Do they have a co-occurring psychiatric illness? You want to see if the OTP has a psychiatrist or mental health provider embedded. And sometimes if there are psychosocial stressors, homelessness, sometimes patients benefit from the daily check-ins, counseling, seeing a nurse every day, so forth. Buprenorphine maintenance, the retention rates are comparable to methadone, efficacy comparable to the blocking dose of methadone, milder withdrawal symptoms, very low risk for overdose. There's a decreased risk of abuse and diversion with the combo product, and it's available. Primary care folks can prescribe it, so there's less restriction on who you can refer to. This is just a table here showing some of the nuances at discharge, seeing what's available, methadone versus buprenorphine. We'll be sending the slides out if you want to revisit those. Something to keep in mind, there's QTC prolongation with methadone. So in the beginning, you get a baseline and then typically like monthly EKG. If the patient's on a co-occurring other QTC prolonging medications, so on Dancitron in the acute phase, or I have a lot of patients who are on antipsychotics, so just checking a EKG from time to time. Credible Meds is a great resource to check if your patient's on other QTC prolonging meds. If the QTC is over 450, usually when you have a conversation. Over 500 is when you DC it, or you wouldn't start it in this scenario. Naltrexone is just showing Vivitrol, the IM monthly formulation, also available in a 50 milligram daily formulation. This just shows the half-life. So at around 28 days starts to dip. If your patient's going away or isn't gonna be able to make an appointment, you can give it between day 21 and 28. And then it shows the steady state of the 50 milligram PO dose. You can see much better retention rate in 6 months with the IM versus the PO formulation of naltrexone. The implant's not FDA approved for OUD. Consideration of pain management. So like my patients on IM Vivitrol, I give them a card that goes next to their driver's license, tells folks in the ED or med surg that they're on IM naltrexone and will need high potency opioids to treat pain in the acute setting. And this shows some factors to consider. Abstinence, so the patient has to be motivated to want to be abstinent, has to be able to detox and be off opioids for at least 7 days. And this is just pro tips going over from methadone or bupe to naltrexone. So again, 5 to 7 days. Linkage from acute care is just a study that shows about half of patients make their injection if they're given extended release naltrexone while inpatient, but a lot kind of drop off. So there's this need for kind of comprehensive services because this is folks who are just referred to a PCP. These are some additional resources that'll be in the slideshow.